Say it again.
You have to be louder.
How do I do that?
I don't know. I didn't follow.
Sir, he was saying, do you have any sins to confess before we start recording?
Oh, okay.
Eldar, you're a tight man. Is 3,000 rupees a lot of money?
3,000 rupees is not a lot of money.
Okay. I'll send you the information, Ananth, about the holder, okay? For your x-rays. He's fortunate enough to have a phosphor-plate system. So the x-rays are a much better shape. Find out the sizes as well, Ananth, okay? I'm amazed that is the RIN system, which I can't believe it's only 3,000 rupees. Unbelievable.
Which one, sir? Which one? The one that Anand is having.
Yes, yeah. It's it's the same one as Abby's going to use as well, because she has the usual X-rays that you develop in Developer, and the phosphor plates are the same size.
Okay.
Make sure I send that to you, Ashwin, okay? Anand. Eldo, have you been able to download the 5 presentations?
Yes.
You have? Okay, that's good. Next problem is to look at them. Okay. What about the paperwork?
We have printed it out.
Yeah.
That's how much you have done.
Right, okay. You know the exam sheet should replace the ones you've already got.
Yeah, I've downloaded only the new ones.
The new exam sheet? Yes, okay. Ashwin, have you noticed the new exam sheet's different?
No, sir. I haven't. I've downloaded all the presentations, but I didn't go through it. I didn't notice it, sir. I haven't noticed it.
You know that on the Aneldo, have you ticked off all the presentations on your checklist?
No.
Do that, okay?
I'll do that.
This is being Aristotelian. Okay, it's how the Greeks and the Germans would do it. It's not in the natural behavior of Indian people. Okay. So keep going on that checklist and print off the forms that you need.
Okay.
Okay. Ashwin, can you call Abby and see when she's coming on?
Yeah.
Let me just see when Tejas is.
Hi there.
You joining us soon?
Yes, 10 minutes.
Okay, right. See you then.
See you then.
Siley, what did you think of that photographic the X-rays needed for children. Have you seen that, Eldo? I can't hear you, Sally. Eldo, did you see that presentation I sent you on children's X-rays?
I had gone through that.
There are about 4 or 5 X-rays on the presentation.
Yes.
You don't have an occlusal X-ray film, do you? Sensor?
No.
What does your orthodontist do?
We don't take occlusal radiographs.
Okay.
Abby is not picking up.
Can you hear me now?
Yes, I can. Yes.
Yeah, I really like the presentation. I intend to get X-rays done for Neil soon.
Yep.
I'll
Good.
send them to you this week.
Yes. How will you get the occlusal X-rays taken?
I can't.
What you might have to do is to take periapicals of the canine regions, upper and lower,
Okay.
because that's where actually lateral incisors are missing as well sometimes. With a child, you might be able to take 2 upper periapicals and 2 lower periapicals anteriorly, maybe.
Maybe, yeah.
Okay. Eldo, how old is your son that has the dentature assist?
How?
How old is your son that has
Nine.
And when did you find this out?
Just few weeks ago, 3 or 4 weeks ago. We did a OPG and a lateral step for his orthodontic treatment.
Oh.
So yeah. And,
what's the location of the cyst?
Yeah, his teeth were flaring. He is just beside me. That is why he's smiling.
Yeah.
Just show me, please.
Eldo, in retrospect, when should you have taken X-rays of him?
Soon after all the teeth has erupted.
Which teeth?
All the pediatric teeth has erupted.
All the what?
Pediatric.
All the deciduous teeth?
Yes.
So what age would that be?
That will be around 6 years.
Is that true?
No, it should be 6 years means. Yes, it is true.
When do the first molars come through?
6 years.
Yeah. So the full dentition, children's dentition, I would think is probably there by about 4.
Okay.
What X-ray should you take of a child of 4?
Bite wings.
Yes.
And anterior white wings.
Possibly.
I think that will give the whole dentition at that time. But I'm not sure whether 4-year-old child will, cooperate.
you're being you're applying your own thinking onto your treatment of your patients. Do you think that Tejas, when his son gets to 4 years old, do you think Tejas will be taking x-rays of him
Okay.
because of his attitude? Okay. How old is your son, Neil? Sally?
6.
Do you think you'll be able to take x-rays of him?
Yes, I think so.
Mm.
The X-ray which I sent you last week, that with that that carious molar,
Yes.
first molar on a child, we
Yeah.
extracted that tooth off with great difficulty.
Mhm. What, because of the child or because of the tooth?
Because of the tooth.
What happened, sir? What was the problem?
I posted that in the group, I suppose. There was a molar tooth, lower first molar, which was totally unrestorable. So we had to extract. The confusion was whether to extract it or to retain that space and to retain that space, or to initialize the molar. So the expert opinion was to remove the lower molar and let the 7 come into that space, and then we'll upright it orthodontically. So we had extracted that tooth off, and it is very difficult to extract because it was the roots were so long, and crown was totally distracted. So it had to be surgically removed.
Did you
Silent
try?
operation.
Did you try cow horns?
Yes, yes. It didn't work.
Didn't
The
work.
whole thing broke off.
Now, what about the major problem? What are you doing about that?
Perio problem.
No, the major problem.
What problem?
The
Major problem.
The major problem.
A major caries. So yeah, sugar reduction. Yeah, that has been told to the patient and the parents.
What changes are they going to make?
Yeah, I have to reinstate that once she comes back again for the suture removal. That time I'll have to reinstate all that.
What are you going to ask her?
To possibly, stop taking sugar.
No, that's what you're telling her to do. I'm saying, what are you going to ask her?
Whether she wants to keep her all the teeth in the mouth.
What about the question of where does the sugar come from that's causing the problem?
Sugar comes from all those.
No,
sugary things.
that's the question you ask her. You understand, Elder?
Yes, I understand.
That's the question you come ask for. Who provides the sugar? Who provides the sugar?
Parents.
No, that's a question you ask.
Okay.
Who else
Yeah.
provides the sugar?
All those shops.
Grandparents.
Grandparents.
Yeah.
Okay.
Okay. Siley, if you've seen that X-ray,
Which one? The occlusal one?
I'll send it to you now. I'll send you now.
I sent you the complete mouth, the panoramic X-ray.
Yeah,
Have
I
you seen
didn't check. No.
it? Eldo's going to send it to you.
I'll send you now.
So what did you do with the dentigerous cyst?
Oh, we had to remove that. Did I just posted in the group?
Yes, sir. No, I
I'll
don't think
post it.
so. I'm not sure.
Have you
That was-
removed the dentigerous cyst?
We have removed the dentigerous cyst, and we took a histopathology examination, and it was found to be luminal unicystic ameloblastoma, which is said to be quite okay. It is non-invasive.
Yeah.
But by God's grace, we are able to find it out in this young age, and we thank God that his teeth are flared. Otherwise, we'd have never taken an X-ray by this time.
Yeah.
And as I'm going to do a presentation to IDA and to the rest of the people, those decision makers, stating that showing all the cases. Our OPG was installed only probably 1.5 or 2 years before, and we could at least find out 8 to 9 cases accidentally of ameloblastoma and huge dentigerous cyst, which the patients were totally unaware.
Now, why do you talk about a panoramic machine when everything you're talking about could be found with periapical X-rays?
No,
And bite
never.
wings?
Never. I'll show you the X-rays, periapical X-rays that I've taken of these patients who were complaining of soreness. Since these patients were coming and telling soreness in English, I couldn't, actually grasp the meaning of soreness that she was complaining. And then I took a periapical and I saw that there was food impaction in between the 7 and 8. And I was treating that only. And then still she was coming to me for 2 years after the 8 was extracted. And then I thought, since you are always complaining of that, and I thought, we'll anyway go for a OPG since you've got many fillings. I'll take an OPG, and my goodness, found out to be a huge cyst at the extracted site. Now they are doing marsupialization for that cyst. And another.
Now, Aldo, just wait 1 minute, okay? You're giving this presentation, and how many of the dentists have a panoramic machine?
No, not everyone will be able to afford a panoramic.
Okay,
but, somebody has to.
So what I'm saying is, you firstly want to encourage them to take the right bite wings and periapicals, okay? Because your son's case is an example where the right periapicals would have shown the problem, okay? So you've got to start with the majority of dentists who don't have I mean, what are you going to do with Siley, you see? Siley is going to take X-rays of a child, and if he had the same problem as your son, she would find it. Now,
I don't think so, because
the next step, no, Aldo, that's not true. The next step for Siley, if she found that, might be to send the patient for a panoramic X-ray.
Yeah, that's what you say is the usual course that has to be followed. But you might think that, for him, we had done a root canal treatment for his deciduous tooth. And then even if we would have taken an X-ray, we'd have thought that it is a periapical lesion that has emerged from the, full, incomplete root canal treatment, which I had done for him. We'd have definitely thought, even some of the doctors whom I showed the X-ray said that, it's just a periapical problem. But I still had a doubt that it is not a periapical problem. So I went for a CBCT, and then I found that it's a huge lesion. And if I had not picked it up at the right time, it would have involved his inferior alveolar nerve, and it would have consumed a lot of his bone structure. Now he lost his lower D and first premolar, and it was quite a big lesion. So, I don't think that, and you see, there is limitation to push the sensor. Probably a phosphor plate could be pushed in a little bit deeper than the RVG sensor. But RVG sensor at a third molar site, it's not practically possible for the patient to bite it down so deep to get a horizontally impacted molar. I don't think so. And then you will not get an idea of the proximity to the nerve with a periapical.
Okay, now
So-
Eldo, let's agree that the first thing that should be done is good periapical X-rays, and if there's any doubts, a panoramic X-ray as well. The fact you've got one is great because you can do both. Okay,
Yes,
it doesn't supplant the straightforward X-rays.
yes, that is
Okay.
true. Yeah, I agree there.
Good evening, Tejas.
Hi, good evening,
Good.
everyone.
Good. Let's get started with the presentations. In just a minute. We are on record, Tejas.
All right.
Now I'm going to go over this fairly quickly, and at the end of it, hopefully, you'll know all you need to know about the temporomandibular joint and what to look for. Eldo, oh, sorry. Okay, just looking at who's got their, can somebody mute that's got somebody talking in the background? Looking at muscle anatomy, this is the master muscle. This is the temporalis muscle. This is the buccinator muscle. These are the orbicularis oris muscles and the mentalis muscles. Those last muscles are not really relevant to us particularly. The medial pterygoid muscle, the lateral pterygoid muscle, all these muscles can go into spasm and you won't tell that it's the muscle that's in spasm. They will have a headache somewhere. And this is the buccinator muscle. Looking from the back, looking forwards at the lateral pterygoid muscles, you notice the lateral pterygoid muscle goes not only from the head of the condyle forwards, but it also goes medially as well. Here's the medial pterygoid muscle. Here's the pterygoid hamulus. This is quite fun, Eldo, because you see this on your panoramic X-rays. Have you noticed it? Spacebar, Eldo. Have you noticed
Yes.
the pterygoid hamuli on the panoramic X-rays?
Yes.
Yeah. Here's the lateral pterygoid plates. So looking at it from a different angle now, the master muscle, the temporalis, the medial pterygoid muscles. Here's the medial pterygoid looking at it from the lingual side. And here's the lateral pterygoid muscle. Looking at the joint itself, this is the capsular ligament. This is the temporomandibular ligament. Here's the styloid process. Here's the lateral pterygoid plate. Is this moving fast enough for you, Ashwin?
It's a little faster.
Yeah.
I'm seeing the capsular ligament now.
That's right. Good. Here's the stylomandibular ligament going from the styloid process down to the sphenomandibular ligament. Thank you, Aldo. Here's the styloid process. This is the mandibular ligament. Here's the head of the condyle. Here's the neck of the condyle. This is the glenoid fossa. Here's the articulate eminence. The cartilage over the head of the condyle. The articulate disc. The attachment of the articulated disc at the back. This is the one that tears when the patient has a anterior displaced disc. This is the attachment to the base of the skull of the disc. The medial pterygoid muscle is attached to the neck of the condyle. Here's the muscle is also attached to the disc as well. And when the muscle pulls correctly, the disc and the head of the condyle come forwards together. These are the two synovial cavities. The synovial fluid in there, in either of those cavities, can get a little bit more gluey. And when it gets more gluey, the disc stays in place a little bit longer when the patient opens, and then it unglues, and there's a small little click when that happens. So when you do notice some clicks, sometimes that's the cause. This is the upper compartment, this is the lower compartment. In normal opening, the head of the condyle and the disc come forwards together. This is a normal disc with the capsular ligament covering it. And you've got the superior belly of the lateral pterygoid, which is attached to the disc. And the inferior belly is attached to the neck of the condyle. So this is a closed position, initial hinge position, which we've talked about. This is normal opening, and the disc goes forwards, and then it goes back like that. The different types of disorders you can have. This is a normal situation. Here's an anterior displaced disc where the disc is in front of the head of the condyle. Here's a posterior displaced disc. I've never actually come across that, but apparently it may occur. And then in older people, the disc can fragment, and the head of the condyle is actually touching the base of the skull in certain places. Anterior displaced disc, we've talked about. Has anybody diagnosed one of these yet? You only diagnose it if you're looking for it. Okay, so if you examined every patient for clicks with your fingers over like this, you're much more likely to find these sort of problems. here's the anterior displaced disc, and as it goes forwards, it goes into place, and then as it goes back, it falls off. You're okay on this now, Ashwin?
Can you repeat that, sir?
You're okay on the anterior displaced disc now?
Yeah, can you please repeat that once more?
Yeah. So the patient at rest is like this.
Yeah.
Then when the patient opens, just at the final opening, the disc clicks into place. And then going back, the disc stays in place, and then it clicks off like that, okay?
Okay. Okay.
So if the patient's got a late click on opening and a late click on closing, it's going to be a reciprocal click.
What is that?
Reciprocal means it happens twice at a different time, okay?
Oh, okay. Okay.
So,
But late, so, okay. Yeah.
okay, so just watch this a minute, Ashwin. The patient's at rest. The patient starts to open, and there's a late click. The disc has clicked into place. Then when they start to close again, the disc stays in place, and then it clicks off.
Okay.
Okay. Now this is looking at it from the front. And here you've got the capsular ligament, and there's the lateral pterygoid muscle pulling forwards and inwards. That's what helps you open your mouth. Now, if it's fallen off the front here like this, the disc, this is at rest. And when the patient opens, it clicks into place. This is a posterior placed disc, which, as I've said, I've never seen one. Anant, you looked at that temporomandibular joint video. Spacebar, Anant.
Yes, I've seen it before, sir.
You've seen it, yeah. Yeah. You saw it, did you, Ashwin?
Yes, I have seen that. Yeah.
Yeah, okay. So this is in an older person where the disc has worn down a lot. A patient may have a closed lock. Where the disc is anterior, and as the patient goes round, it stays without being recaptured. That can happen, okay?
Can you repeat that, sir? Sorry.
Do you see these three pictures?
Yes.
The four pictures.
4 pictures, yeah.
You see the disc is in the same place compared with the head of the condyle.
1 second, sir. Okay. Yeah. Yeah.
So it hasn't been recaptured.
Oh, means it doesn't move into recaptured means, what do you mean?
It's still anterior to the head of the condyle.
Okay.
You see in picture A, the first one at the top there, you've got attachment above the head of the condyle, and the disc is in front of it.
Yes.
The same thing in the second one, B.
Yeah. Yeah.
The same one in C.
Mhm.
Oh, what happened then? Now, fortunately, deformity and disability are not always interrelated. I'll explain. The fact that somebody's got a click does not necessarily mean they've got a problem that they face every day. Okay. So you will come across a lot of clicks if you look for them and the patient has no problem. But the prosthodontist amongst you, if you're restoring patients and you don't check for clicks to start with, and you restore a patient and then they say, I've now got a click, you're in a difficult situation because you haven't recorded the fact that the patient's got a click. Everybody clear on that? Now, when I first was planning my first presentation on appliance therapy and the treatment of headaches and temporomandibular joint problems, I may have mentioned to you that when I went to the patient's notes to use some of these patients as examples, my notes were appalling. And I didn't have the right sort of information. So I know that you, Eldo, have talked about patients that you've had with joint problems. And I think that in order to look after these patients really well, you need to take very good notes and do very good examinations of them, because the maxillofacial surgeons and the oral surgeons don't know what they're talking about in terms of these sort of problems.
So please let Abby in.
Thank you very much. Okay, hi Abby. You look like a Muslim with a beard.
Hello, sir. Hello, everybody. I didn't hear you, sir.
I said you look like a Muslim with a beard. With your black thing on. By the way, can you imagine that the governor of Texas has told all the Texan people they don't need to wear masks anymore?
Yes, I've heard. I heard the news.
wasn't it appalling?
Yes. Yes.
But at the airports, the airport people say you have to. So they're being, you know, much better about it. How many of you have printed off this form? You printed off this form, haven't you, Abby?
Yes, sir. I do have.
Okay.
I'm
Yes,
just
I have.
You have done, good. Okay. I find it much better visually writing stuff down on a chart like this. I can immediately pick it up much more quickly than if I have to read a whole lot of writing. So you can use one of these for muscle palpation findings. You won't have any muscle palpation findings unless you palpate some muscles, obviously. Okay. Has anybody got this sort of form as well? Have you printed any of these off, Ashwin?
Yes,
I
not
have.
yet.
You have, good, okay. So it's interesting to write down here all the symptoms and signs and then see how they progress. An important thing is to record all this stuff, because then when you see the patient in 3 or 4 years' time, you say, how are you getting on with this, 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 and this? They say, oh, what do you mean? You say, well, don't you remember when you came to me first, you had all these problems, because they forget them very easily. So here you record the date. You put the day and the month there. Here you record the progress, which I'll show you. You put P for present, arrow up for the sign or symptoms increasing or decreasing, and then further notes down here. And here you put the date of your information. So how many of you have got this form laminated? Yep, good, Eldo. Yep, yep. You're going to have to go.
Why do we need to laminate this? I mean,
because you have it laminated in a drawer just next to you where you're working.
this, I thought you have to take it on with the patient when the patient comes.
No, I didn't do that. Okay, you can do that, but it's just easier to have it laminated and just go down the list yourself. Okay, that's an alternative. Okay, so looking at headaches, migraine, the time of onset, how long it lasts. I think one or two of you have mentioned patients who had problems first thing in the morning. If a patient has a headache first thing in the morning, it's most probably an occlusal problem. Okay. The type of pain, how intense it is. Sorry, Sally, I can't hear you. Where the pain is, the direction that the pain goes, the headache.
Can you type in Sally? I mean, it's not audible.
Type it and then Ashwin will read it to us. How it changes in character, how often they have headaches. You'll find some patients say, oh, do you have headaches? And they say, not very often, no. And you say, well, how often do you have them? And they say, oh, 3 or 4 times a week. To them, it's the normal thing because they may have had them for years. Precipitating factors. Tejas and I don't know about this alcohol causing headaches, do we? Stress certainly does.
Lack of it causes headache for me.
The lack of it, yes. Okay. Alleviating drugs, analgesics, sleep. I had a patient come to me with some sort of problem. I forget whether it was joint trouble or headaches, but he was taking about 3 or 4 different types of pill. He'd seen neurologists, maxillofacial surgeons, physical physicians, and he had an occlusal problem, which I corrected. And when I saw him some while later, I said, "Have you taken any pills recently?" And he said, "Well, I took some Panadol the other day because I thought I was about to have a headache." Associated symptoms with migraines, they can have nausea, dizziness, an aura. An aura is when they have this feeling that a migraine's coming on. Has anybody had a patient with an aura? Yeah, okay. Dental practices, there are some dental practices, quite a few, where none of the patients have migraines.
Sir, can I just read Siley's message here? She says, a friend of mine has sent me a message. My whole body pains from morning because of shallow breathing and open mouth at night. I can feel my lungs compressed and neck and back pain because of it. Please let me know if anyone is doing the BioBlock thing. Can this be related to occlusion? That's a question.
I think the patient needs a psychiatrist. You see, I'm totally pragmatic about occlusion and headaches and temporomandibular joint troubles. If they've got occlusal problems in terms of interferences and you sort them out, it sorts out that problem. If it sorts out the other problems, I'll take credit for it. Okay. So, Siley, I would have the patient examined thoroughly from an occlusal point of view and a jaw joint point of view, and then see what that shows. Okay. As I said to you before, there was one patient ended up with 10 symptoms and signs. And when I treated her, she ended up with only 3 or 4 signs. So that's progress. Okay. They can have visual changes as well. People with migraines. People clench their teeth, as Abby's patient has a problem with that. Grind their teeth. Sinus problems. Patients with sinus problems, were you ever taught to have the patient lower their head between their knees? You know that, Tejas? Do you know that, Abby? If the patient has acute sinusitis, when you tap their teeth, they're all sensitive in the upper. And when you have them lower their head down, the pain gets worse. Okay, so it's an important thing to check. Okay. These are all the problems you want to check with patients with migraines particularly, but the same thing with headaches, ringing in the ears, tinnitus. I had one patient who had tinnitus. I adjusted her teeth and the tinnitus went. I hadn't quite finished adjusting her teeth, so she came back and I did a little bit more and the tinnitus came back again. And then I did a bit more adjusting and then the tinnitus went. Just one case, okay? So if a patient has tinnitus and you do something about the occlusion, say to them, it may have no effect whatsoever, but it's going to help your teeth. And then if the tinnitus gets better, that's great. You can claim success. So you take down a history in terms of whether they've got pain in the neck, the shoulder, the back, the chest, all this sort of stuff. And you can always claim success if you get rid of any of those. Ask them when they first noticed the problem, how it's changed over the time. When's it got worse? When's it got better? Have they had any car accidents or any blows to the head? What have they taken in the past? Analgesics, tranquilizers. I had one patient I'll show you a bit later who was put on Tegretol for trigeminal neuralgia, and I made her an occlusal appliance and she didn't have to take the pills anymore. Are they on antidepressants, muscle relaxations? How many of you have suffered from diagnosed depression? Anybody? Okay. I'm sorry you haven't, because if you have...
Undiagnosed.
Sorry?
Yeah, how to diagnose?
Undiagnosed.
Undiagnosed, okay. I think if you have, you're much more empathetic to people who have depression. You see it in their face, okay? I know Eldo's not keen on this, but if you just look at somebody and just notice the fact that they look depressed, it has an effect on how you look after them, okay? They need a lot more tender loving care than other patients.
I have a few patients who've survived cancer. They're in remission now. And every time they come in, they spend at least half an hour talking to me, not about dentistry. So it's basically when I talk to them, it's about how challenging their journey has been, and how they, at some point of the journey, they've been depressed and now they're out of it. And every time they come, there's a story that they tell me about their journey. So it's quite rewarding, actually. And now I think for those reasons, I think I should switch to charging by time.
I was keeping quiet. You see, unless you have a fee, you don't get interested in things. So how are you going to work if a patient comes in and says, well, I've got a bit of pain in my joint here, and you say, I need to do a thorough examination and see what the problem is. Just wondering. Has Ashwin joined us?
Anand, sir. Anand.
Okay, right. Now, if you don't have a fee for these sort of things, and as I've said to you before, along with what Tejas was saying, you book a patient in for a mandibular block and 3 fillings, and they come in and their grandmother's just died, and they're very upset. So you talk to them for a certain amount of time, and you do 1 filling, and you get paid the same. Now, what value has the patient got out of that? They got tremendous value out of it. They've only got one filling, but they've been, you know, cared for. So if you're working on the equilibrator, it's not a problem. And the patient knows this to start with. Okay.
I'm off camera. I'm going to be on audio. Okay. I'm going to be driving, but I'm going to be in the conversation.
Okay, fine. Okay. Now, Tejas, when you go on the hourly rate, it's so much easier for you to say, you know, your appointment will be for such a time, and then this is the likely fee. It's so much more flexible than having a unit for each treatment. I look forward to it when you do. Let's just continue on here. The amount of things that patients have been put onto because of their occlusal problem without actually dealing with the problem is tremendous. Stress history. Start thinking about asking patients about their lives and what's putting them under stress. You find that when you start doing this sort of thing, you may think that you shouldn't be doing it. But as you get more and more involved in patients with headaches and temporomandibular joint problems, the more you are skillful in dealing with the patients and talking to them. Abby, are you asking patients how they feel about dentistry?
Yes, sir. Recently, I did last, I think Sunday, sir.
Yeah.
One of the patient was very eager to learn everything. So I taught him toothbrushing techniques. I introduced that paper, the bleeding index. I took the bleeding index.
Good.
That chart I made and everything.
Have you got some, Abby, have you got some toothpicks now from Ashwin?
Yes, sir, I do have, yes.
Yeah. Are you using them?
So I'll be giving him after I'll see a positive reaction from him. Like he is kind of positive regarding the brushing. So he learned brushing and he is actually doing it. Every time he comes up and he tells me, yeah, this is the problem I'm facing, this problem I'm facing, and all that. So after 2 or 3 weeks, then I'll introduce him to toothpick. This is what my plan is.
Now, you see, my view on that is that most people in the UK use a toothbrush. Most people do.
Okay.
But they don't use a toothpick. So I always introduce a toothpick first.
Okay. Okay.
And then when they come back after 10 days, they say, oh, there's much less bleeding now.
Okay.
Have you got any little bamboo toothpicks yet, Eldo?
No, I don't have bamboo ones. I only have barments.
And you haven't you? Yeah. How are you going to solve that problem?
Yeah, I have to get it from the local cheapy guys.
I only know one supplier of bamboo toothpicks. Ashwin.
Who needs bamboo toothpaste? Toothbrushes?
Sorry?
Who needs bamboo toothbrushes?
No, bamboo toothpicks.
Bamboo toothpicks.
Okay.
Yeah, you're seeing?
Always bear
It's
in
pretty
mind.
cheap, sir. Just 5 rupees a packet. But it's good. I mean, it's not as good as Barman's or Dr. Tung's, but it
gets the
serves
job
the
done.
purpose. Yeah, it gets the job done.
Not clear.
Can you send me some, Ashwin?
Yeah, sure. Just let me know, sir, how many pieces you want, how many packets you want.
About say 5 packets.
No,
What?
5 is it's no 5 is
100.
too less, and
Sorry.
How much?
Packet
How
cost
much
you
is
5
100?
rupees.
How
You
much
can
is
order
100, Ashwin?
100
just
100
5
packets.
It's just 5 per packet. 5
5
per packet.
Give me 100 packets.
Sure. I'll do that. Yeah.
Elder, how many do you want? Elder?
I didn't. It was not clear.
How many do you want? How many packets?
I don't know.
20 packets.
TJS is going for 100.
Say 110.
I don't know whether he.
Say 110. Eldo, you could get through 100 packets in a month in your clinic. Anyway, let's move on.
Sir, I'll meet you in 30 minutes, sir.
Okay, it'll be recorded anyway. Okay.
Okay, sir.
History taking for the temporomandibular joint. Ask the patient themselves what their problem is. What sort of noises do they have? Do they have clicking, popping, grating, crunching, whatever they say? And does it happen during eating? Do their jaws lock? Do they have stiffness? Somebody in America sent me an email the other day about how to, he had a patient who locked open lock, and they couldn't close. Has anybody ever reduced somebody with an open lock? You have.
have.
Yeah. Well, you put the thumbs on the molars and your fingers under the jaw, and you ease it down the head of the condyle. Yeah. Haven't done it for years. So these are all the things you need to find out. Do they have a problem when they're eating? When they're grinding, or do they grind or clench? Have they had a direct blow to the jaw? I had one patient who had a direct blow to the jaw. I'm not sure that whatever treatment we do makes any difference to them, unfortunately. Do they open excessively? Some women open their jaw really wide and they click, and they have to be told not to open their mouth so wide. I haven't come across with men. It may happen with men as well. Do they have a problem when they're yawning? Have they had a general anesthetic recently? Because then they're opened up too wide sometimes with the mouth gag. Have they had a dental procedure recently? I'll tell you about 2 patients that I have with a problem having had a long procedure. So all these things you need to record. So patients with jaw joint problems, you also want to check whether they have all these other problems. How long they've had it. You can write a whole page about some patients. Now the clinical evaluation, hinge position, we've talked about. TJS, are you using bimanual manipulation? Is TJS around? No. Ashwin, doing this is a very inaccurate way. You must put your lower fingers along the lower border and your thumbs on the chin and do it properly. Okay. Are you increasing, Elder, in the amount of times you're doing this?
Yes.
I don't think he heard it.
Sorry, are you listening, Elder?
Yes.
So what's the answer?
Yeah, I've been doing this.
Good. I mean, I think every single restorative patient you treat, you should check before their occlusion beforehand.
I'm going to make a stabilization splint for me.
You're going to do what?
Your appliance, hinge appliance.
You are.
I've ordered a 6 retainer.
Why?
Because you wanted me to make one. You said,
What do you mean
"Why
by an
don't you
Essex?
make it carry for some time? Let me see how it works."
What do you mean by an Essex?
S6 is the plastic initial
Template.
tray that comes out the teeth. Suck down, suck down.
Yeah, it's. I don't think. Do you call it an Essex? I call it a suck down shell.
These lab guys call it an S6.
Are they using a spacer?
No.
Yes, sir, they do use. They use a spacer, usually. That is, hello, am I audible?
Elder, will you make a note? Will you make a note to look at how to
Yes.
make a suck down shell?
Okay.
If you don't have a spacer, it'll be uncomfortable. Okay.
Okay.
You all know about checking the jaw joint like this. The important thing is to do it in stages. Open, close, going to the left, coming back, going to the right, coming back, going forwards, coming back. Each phase, because that's when you want to record when the patient has the problem, if they do. Has anybody done an examination of a patient with fingers in their ears? Okay, yeah, good, okay. It's more accurate, but it's also more invasive from an emotional point of view for the patient. Now, muscle palpation. These are the muscles we're going to look at now. And on your chart there, Ashwin, you can use a felt pen that's erasable on your laminated sheet if you want to tick them off. Okay.
Okay.
So you firstly start with the temporalis and then the masseter muscles. It's a good thing to do them both at the same time, okay? Because then they can compare.
Yeah.
Okay. Right one's a little bit more tender than the left. Okay. We'll look at this in a minute. the sternomastoid muscle. I had a dental assistant who had a very sore sternomastoid muscle about halfway down from the skull. The medial pterygoid muscle is a little bit more tricky to because it makes the patient retch a little bit. The lateral pterygoid is more difficult to get to, as we'll see in a minute. Now, Ananth, you notice I'm not wearing gloves. And my question is, were you wearing gloves in 1980? Okay, so about 1/3 of my life, we didn't wear gloves. Okay. Ashwin, just for your curiosity, this woman I lived with for about 5 years. Would you admit that she's quite good looking?
She is.
Have you seen this person before, Aldo?
She should be the woman opposite your house. Janet. I forgot her name.
No, it's not. No. Vivian. No, certainly not.
Vivian. No.
No. This was the girlfriend I lived with for about 5 years.
Okay.
And I can assure you that if you looked at her now, you'd be horrified. She's not the pretty picture she is here. This is
the doctor is also a handsome man with
That's
mush.
right. In those days. Thank you, Elder.
Okay. I think you look better with the mustache like us.
Well, like you. Now, everybody, palpate your master muscles. Okay, palpate your master muscles. Both hands. Okay, just go up and down the master muscles. We'll have to get Ashwin to do this in a minute because he's gone off somewhere. Now the sternomastoid muscle, you have to put your hand on your jaw. And try and make it bigger and feel it. Can you feel your master? Put your hand on the other side. Eldo, listen to me. Put your hand on your jaw the other side, like this. Eldo, look at me. Do this. Do this, Eldo. Okay, now feel the master on your other side. Keep your hand there, and with your other hand, feel your sternomastoid on the left. Okay. It brings it out a little bit. Okay.
Okay.
Can you repeat that? Sorry, I missed it.
Okay. Ashwin, go back and palpate the master muscles here. Like this, both hands. Okay. Did I tell you, Ashwin, that this is the woman I lived with for 5 years?
Yes, I finished that.
You didn't miss that. I didn't want you to miss that. I didn't want you. The first 5 years are the best. Okay. Now, these are the sternomastoids. Okay. Sometimes you want to stand out more. Can you feel them, Ashwin?
Yes.
They're going from your sternum up to your skull. Okay.
Oh, sorry.
Now this one is where you put the local anesthetic for your mandibular block. Okay, so you have to stick your finger in. Can you feel that, Ashwin? It's just on the inside of the ramus.
Yes.
Both sides. Okay. Now the medial pterygoid, you have to put your finger up on the inside to the back, on the outside of your teeth, and go up and move your lower jaw to the left, the opposite side.
Sorry, once again, you place it on the right side, on the left side.
You run your finger along on the top. The other side, Elder Ashwin. The other side. Your first finger on the outside. You can do it on the inside at the back. Yep, Elder Ashwin, you move your jaw to the same side. Put your finger in there. No, your other hand. No, on the outside. Like this. You've got your hand like this. You're going to be like this. That's it. You go inside your molar teeth. Turn your hand around so the pad of your finger's touching your molar tooth.
Okay.
That's it. Yeah, that's it. That's one way, Eldo, on the inside, but you can do it on the outside as well. Move your jaw to the left, Ashwin. Right at the top there. When you have a patient who's got a problem, they'll certainly notice it. They'll jump. Okay.
So this is for the medial pterygoid or lateral pterygoid?
Lateral pterygoid.
Lateral pterygoid. Yeah.
Okay. If you do that on somebody with spasm of the lateral pterygoid, they'll certainly feel it. Okay. As pain. Now, resistance testing. Okay. The patient moves their jaw against resistance. So if you put your hand on your forehead and your fingers, your thumb on your lower jaw and open. Okay. Eldo, hand on your head. Eldo, you got two hands. That's it. Okay. Now try and open. Okay, that's opening against resistance. Now,
this is to test the masseter.
Sorry?
Hello?
Let me just think about that in a minute, okay? Yes?
Hello?
Elder, you've frozen, I think. Now put your finger, your thumb on your upper teeth and your finger on the lower teeth like this. And bite. Okay. Now, put your hand on your forehead and push against your hand, your hand like this, and then like this. Okay, that's it. Now, if it's a muscle problem, primarily, you're going to find that they get pain in a particular muscle. Okay, so that's muscle testing. Oh, one, put your finger and thumb on your chin and push your jaw forward. Push your jaw forward. Now put your finger in your mouth over your teeth and pull back.
Is that
Ashwin, put your first finger over your front teeth. Finger over your front teeth. Teeth.
Oh.
Ashwin. Finger. Finger. Your thumb under your chin. Finger over your front teeth, like this. And pull back.
Yeah.
Pull back with your finger, your thumb and your first finger. Okay.
Okay.
Now I did this with one patient, and it was only at that point, the patient really was in pain. Okay.
What does that mean? What does that suggest? I mean, what muscle could be affected?
I think you're pulling against the lateral pterygoid. Okay. Yeah, you're pulling against the lateral pterygoid because the lateral pterygoid is trying to open.
The lateral pterygoid helps us to open. Yeah.
Is the one that's trying to open. And what you're trying to do there is you're pulling the jaw forward. They're trying to pull back. But Eldo, Ashwin, whatever muscle gives pain, you just make a note. Okay. You're building up a much better. You're building up a much better picture of what the situation is. Okay.
Okay.
Range of movements is something you need to record as well. Okay. What is their maximum opening? And what is their stretch opening? Okay. Now, if you open your mouth as wide as you can, you then measure between the incisors, upper and lower incisors. Okay. And then once you've done that, you do this. You can stretch them a little bit more open. Ashwin, put your thumb on your upper teeth and your fingers on the lower teeth and stretch downwards.
Yeah.
Okay. Some patients you might find just there's no difference. Okay. There's as wide as they can go. And when you do that, they can't go any wider. And you record the pain or any discomfort when you do that. Horizontal movements, you measure between the tips of your upper front teeth. A slight limitation is about 30 to 40 millimeters opening. Moderate is 20 to 30. Moderate severe limitation is about 10 to 20 millimeters.
How do you measure this?
Okay.
No, 1 second.
You measure with a ruler.
No, I mean, this was for horizontal movements, right? Horizontal.
Open.
Oh, open.
Opening. Okay, I come to you and I say, I've got limitation in opening, and I go, and you measure it.
Yeah, oh, got it.
Got it? Okay. And then you do some treatment, and then you check them again. You say, oh, do you see it's twice as much now? That's great.
So what you said something on horizontal stretching. What is that?
Wait 1 second. Movements left to right, 9 millimeters is normal. That's between the center lines. Okay. Okay. So if you had somebody there, Ashwin, you could ask them to go to the left, and you can measure the difference between their center line in the upper and center line in the lower.
Right.
Protrusive 9 millimeters, you can measure that as well. Okay. So you see on this list, Ashwin, you've got all these things.
How do you measure protrusive? You place a scale on the tip of the upper anteriors and then measure.
You put a ruler in the mouth and measure how much further forward the
from the anteriors.
Yes, it's a comparison.
Okay.
It's going to depend on the person's jaw classification as well.
Okay.
So you measured it one day and it's say 5 millimeters, and then you measure it later on and it's 9 millimeters.
Okay.
So you can say how much they've improved. Okay. What do they call it? Value added, something or other. Value added. Not only have they got the product, but they also feel better about it because they can see it's better. Okay.
Yeah, value added tax.
Is it? Now, some of these things I'm putting in here just for completeness sake. You can get them to bite on some tongue depressors in the anterior region, left and right, posterior, or both sides, like this. Okay. You could always get them to bite on a cotton roll or something or other. And they can tell you what symptoms they've got. Anterior displaced disc, we know about that. Chewing test. So I get real pain when I chew food. You can give them some wax and get them to chew on it and tell you where the pain is. Now, I'm going to show you something which I've done once in my life, just to show you that I'm a real man. Okay. If the patient has restricted opening, like the one I'm about to show you, you can put some local anesthetic in the muscle you think is in spasm. You firstly start measuring the maximum stretch opening. You then inject the muscle. I use lidocaine without adrenaline. And then you record the maximum opening afterwards. So I felt with him opening and closing where his head of the condyle was, and you can in fact go just in front of your ear and there's a depression just between the head of the condyle and the coronoid process. I should use your first finger, Ashwin. Just in front of the coroner. If you can feel where the joint is, and then just go a little bit further forward, you can feel a depression.
Yeah.
Okay, so you have the patient open just a little bit. I used some surface anesthetic. No, I used some alcohol spray, and then I used a jet gun just to anesthetize the surface. And then you go in with a long needle all the way. I want you to do this tomorrow, Ashwin. And you put the local anesthetic in. Now, this patient could hardly open more than you can see now. All right. And then he's opening up this much.
But once the anesthetic effect is gone, you go back to the same position, no?
That's exactly what happened.
Oh.
Okay.
I thought it would disrupt the muscles and then.
No, I have a funny feeling it probably would make the muscle even more irritated.
Oh.
Did you do it on both sides or only on one side?
No, when I did that test, pulling back on the lower jaw, it was only one side that hurt.
Oh.
All the tests showed lateral pterygoid on one side was painful.
Mm-hmm.
Okay. If you went to a temporomandibular joint special clinic in America, they'd go through all these things. Okay. Whether their results would be any better at the end of it is another matter. Okay. Because unless you can make hinge appliances and anterior repositioning appliances and adjust occlusions, all this is a waste of time. If your doctor takes your blood pressure and doesn't know what to do about it if it's low or high, there's no point in him taking the blood pressure of you.
How deep do you inject? Like, how deep does the needle go in?
Push it.
How deep?
The full length of the needle.
Full length of the
How
needle.
long was it?
I don't know how long a long needle would be.
1 inch, 1.5 inch?
1.5 to 2 inches, I should think.
Okay.
Yeah.
Any complications that could arise?
Broken needle.
Oh my God.
I only did it because at the time I was really studying temporomandibular joint problems. And I'd gone through a number of books on the problem. And I'd attended a 2-day lecture on the temporomandibular joint. That's where I first came across the anterior displaced disc. Okay. I mean, I know Eldo.
Yes.
Can you imagine what Prisley does with what I'm saying?
Yes.
Prisley is a friend of Eldo's and mine, who is a, what do they call it? He's a, do you know the word nerd?
Yes.
Okay. He is a nerd I mean, Ashwin and I are nerds, but this chap is 4 times the nerd. Okay, so he will go into, Aldo, what I'm talking about today in such fine detail, and spend hours at it. And I don't know whether he gets any better results or not. Okay, so I'm being fairly gentle with you today because I'm not sure you need so much more information. The other test is using a cold spray, like ethyl chloride here. Or you can use, Siley, that spray you use on a muscle that's got muscle spasm. And it anesthetizes the muscle and lets it relax for that period of time. And then when the spray wears off, Ashwin, Eldo, what happens?
What is that?
When you spray the muscle and it relaxes,
Yes.
and they can open their mouths better,
Yes.
what happens when the coldness goes off?
It's kept open.
So it goes back to the same position.
Yes.
Okay.
But if you can do some caustic thing injection, that would disturb or dissolve some amount of the muscle.
That's for you and Ashwin to do, not me, okay? I'll leave that to you. Temporomandibular joint x-rays. This is my temporomandibular joint x-ray machine.
Oh.
Okay. Unless you've got one of these, you're just not one of the men, okay? I can't say I've remembered where it is, and I don't think I've seen it for 20 years. I had a patient that when she opened, just look at me a minute, when she opened, she went like this. Okay, now what's your diagnosis?
Ankylosis?
Hmm?
Ankylosis?
Well, in the severe situation, yes. Which joint?
Opposite side.
Same side.
No, which ones stayed still?
Affected side.
Anant, you impressed me more and more each time you have come on a session. If you moved your jaw to the right like this, which condyle stays still? Put your fingers in your ears and feel. Ashwin, 2 fingers. Put 2 fingers in your ears. Little fingers. Little
I can't
fingers.
hear you if I am using an earphone.
Little fingers. Okay, now go to the left. Which condyle stays still?
Left.
Okay, so Ashwin, Eldo, not this lady, but this young girl I was treating who went like this. I took temporomandibular joint x-rays of her both sides, resting, closed, and open. And I found that her right condyle did not move on the x-rays. Okay? Ashwin,
Yes, sir, listening.
I then, when she came in the next time, put my fingers in her ears and had her open. And guess what? The right condyle didn't move. So I could have found that out without taking those x-rays. Okay. But it taught me a lesson. And I've never, ever found that temporomandibular joint x-rays have helped me in the slightest bit. Mind you, if you're working in a temporomandibular joint clinic where they're getting every patient comes in with a joint problem, you're more likely to find somebody with arthritis and things. Okay, just looking at these forms now, which we looked at earlier. You can use the top one for headache recording, and the bottom one for muscle recording, or the other way around, whichever you want. This form I've shown you. So here we have a patient who has pain on palpation in the temporalis muscle. Also pain in the sternomastoid. Now, when I come to look at the patient's notes, I don't have to read that, I can just see it. He had a sharp shooting pain going from his joint upwards into his skull, and a pain in his neck, which was really painful. So this was his sheet, which has got sharp shooting pain, pain on the right side of the neck, pain on palpation on the right side of the neck, and pain in the temporalis. We can see that on the 10th of March, the shooting pain, sharp shooting pain had gone down. I'd taken out his upper right wisdom tooth, which was over erupted. You've seen his case on models many times. The pain on palpation of his neck had gone completely, and the pain in the temporalis had gone, it was lessened. Having taken out the other wisdom tooth and done some equilibrating, all the symptoms were absent. And they continued, I forget what year, this was 2015. This is true today now, when I talk to him. So I've written down the symptoms here each time. Okay. Now the thing about this, Eldo, is that, does that impress you?
Yes, very much.
It impressed me too, okay? Looking at it impresses me, so that gives me the extra enthusiasm.
Yes.
It's like, Anant, when you look at the bleeding index you did the other day, if you were to see the patient in 3 months' time and find it's gone down to half of it or much less, that impresses you too. This is another patient. He's got pain on palpation on the right side of the jaw. He's got pain in his, on palpation in his masseter muscle. He's got a pain that shoots up his face, sharp shooting pain, which he gets occasionally, and he gets frequent dull headaches. So here are his symptoms. And you see in 1989, after treatment, he had no symptoms at all. And then in 1992, still no symptoms. And I could say to him in 1992, do you remember the dull headaches you had? Do you remember the shooting pain you had? Do you remember the pain you had in your muscle and the pain you had in your joint? And he's going to say, oh yes, I've forgotten about that. Thank you, Stuart. Okay. The advantages of follow-up are the patient sometimes forget that they had signs and symptoms. At recall, going through their signs and symptoms reminds them of what you did for them. Some patients maybe have numerous symptoms, like 7 or 8 symptoms or signs, and they may, at the end of treatment, have 2 to 3. So the world's a little bit better for them.
Shall we stop? I'm feeling very sleepy.
Okay, what time is it?
10:20. I think I had vaccination yesterday.
Oh, you did, sir. How was it?
Very cool. Just 1 second they finished it. I didn't even know that they're about to inject.
Any symptoms? Any issues?
I don't have any symptoms at all, but Anu is totally down. Our 2 of our staff is totally down. Rest of them have got muscle pain. I am perfectly fine.
Okay.
Covishield, Oxford.
Covishield.
Ananth, can you email me your address, your home address, okay? Email me. Okay, so everybody make sure they've looked at the complete examination presentations thoroughly, okay? And print off the forms you need, okay? And get everything ready you need. And the checklist that I sent you, try and have a clipboard for it and tick everything off as you go, okay?
What is it? Print everything down and?
You got to print do everything it says on the checklist that I sent you.
Okay.
So you when you've looked at each of the presentations, tick them off on the in the brackets.
Okay.
Okay, and then you go around and make sure you've got everything else for the examination, the forms and everything. Okay, and then when you do the examination, use the checklist at the top of the form, of the examination form. And then when you've done that, tick everything off on the checklist to make sure you've done everything, okay? and then start doing your examinations a little bit more thoroughly. Okie doke.
Okay.
Thank you.
Thank you.
Thank you
Pleasure.
very much. When are you
We'll,
going to get vaccinated?
say it
Stuart?
again.
When are you going to get your vaccination?
I've had one.
You had one? Oh, really?
Hmm.
Okay. So they recommend 28 days after the first shot.
In this country, it's 3 months.
Okay, the same
3 months.
vaccine in this country, they say 28 days.
Yeah, they're also thinking, they're trying to work out whether or not you can have different vaccines. Okay. Logically, I can't see it matters which one you have. If you have one, you know, the Oxford one, and then the next one you have the other one, doesn't matter, okay? I think that the UK have been very good about vaccinating, better than some of the European countries.
Okay, okay. Yeah. Yeah, mommy പറഞ്ഞു ഇച്ചിരി കൂടിയെന്ന്
Okay,
പറഞ്ഞു.
Aldo.
Okay,
Thank you
bye.
for being with us, everybody.
Thank you. Thanks to you.
Thank you very much.
We'll see you
Bye-bye.
again, Sally. Cheers. Cheers,
Yes,
Anand.
bye.
Bye. Bye. Cheers, TJS.